move on to our next session. So our next session is a debate. The topic is proton beam radiotherapy is not better than photon radiotherapy in locally advanced lung cancer. And to speak for the motion, we've got Dr. Ahmed Salem. So he was in Christie as a consultant clinical oncologist, but I heard he recently moved to Jordan. So as you all know, Christie is the first center in UK to got proton beam radiotherapy. So Dr. Ahmed Salem is a consultant clinical oncologist at Afia Radiotherapy Center, Amman, Jordan, assistant professor in Hashemite University in Jordan, and an honorary senior clinical lecturer in Manchester University, UK. So over to you, Dr. Salem.
Hello. Yeah. I hope you can hear me fine.
Yes, you can.
Okay, so thank you very much, Animish, for inviting me. It's a pleasure to be part of this informative meeting. And yes, I was in the Christie till very recently, and I actually led the efforts to treat the first patient. So that should hopefully give more credence to my debate here. So these are the topics that I will address. So first, I'll go over the medical evidence on the role of protons in lung cancer. Then I will address why I think the routine use of protons before a clinical trial is actually published showing their usefulness could potentially be detrimental to our patient group. And lastly, I will address why it is actually not practical to use protons in lung cancer in the current treatment landscape. But first, I think it's wise to do a quick introduction. So we've heard this today. We know that lung cancer is the leading cause of death worldwide, and it is indeed a significant economical burden. We also know that non-small cell lung cancer is the most common lung cancer subtype, and that patients who have stage 3 disease constitute around 20% of these cases. And I agree with the previous speaker. There is no question in my mind that there is a significant unmet need when it comes to improving the outcomes in this patient group. However, I think we need to be very mindful that there is currently no medical evidence to support the use of protons in lung cancer. And I think my respected debater will probably show you that these results and will try to make arguments why this was indeed a negative trial. So this is an important study that included patients with a stage 2, 3, and also selected oligometastatic stage 4 patients. These patients were treated with concurrent chemoradiotherapy, and they were randomized only if they had met pre-specified dose parameters to either state-of-the-art photon technique, so IMRT, or a passive scattering proton approach. And I suspect my debater will probably comment on this and say that this is considered an outdated proton technique, and I would agree with that. But please note that both the co-primary endpoints were negative for this trial. So grade 3 or higher radiation pneumonitis or local failure were indeed similar between the two groups. And you can see this clearly in the curves here. So I would say, so no matter what you hear, this was a negative trial. And anything apart from that is indeed a fake news. I'd probably agree that, yes, the authors have reported a lower splash dose to the heart and lung, and this particularly pertains to both low and medium splash dose. And also, they reported that both of the endpoints had improved over the course of the trial. So patients who were recruited after the study midpoint had better outcomes when it comes to these endpoints than before. And this obviously showcases a possible learning curve. So I think we can conclude using this trial that outdated proton, so passive scattering proton technique, is definitely not better than state-of-the-art photon approaches using IMRT. But what about intensity modulated proton therapy? So what about the state-of-the-art proton techniques? Well, this retrospective study addressed the use of a proton spot scanning in lung cancer patients. It involved 64 stage 3 non-small cell lung cancer, nearly half of which were treated with spot scanning protons, and the other half received intensity modulated photon radiotherapy. And again, similar to the previous prospective trial that I had just presented, the authors did not see any statistically significant differences with regards to toxicity, overall survival, and progression-free survival. And you can see this clearly with the Kaplan-Meier curves, which are overlapping. So again, this is a negative study. And what is nice, I would say, about that particular retrospective cohort is the fact that they have reported on hematological toxicity. So we know that this is important because severe reduction in lymphocyte count or lymphopenia, we know that this is now an established poor prognosticator in lung cancer patients. We also know that lymphopenia occurs quite commonly in non-small cell lung cancer patients treated with chemoradiotherapy. And this seems to be related to an increase in dose to central thoracic structure. And you can see this area here. And while we know that protons, at least from a previous retrospective study, seem to be able to reduce lymphopenia in an esophageal cancer dataset, this was not the case in the retrospective study that I presented. And here, what the authors reported was that both the neutrophil and the white blood cell counts were not dissimilar, so were the same between the two groups, albeit that they did not specifically look at the lymphocyte count because they did not have that data. But you would assume if neutrophil count and white blood cell counts are not dissimilar, so they're the same, you would assume that probably lymphocyte counts were also the same. So if we go back to the first question, I would say the answer to it is that we currently do not have any medical evidence to support the use of protons in lung cancer. And I would say definitely we do not have any level 1 evidence. And actually, up until today, the results have been fairly disappointing. And while my debater will probably argue that there is dosimetric advantages, which have been reported in previous studies, they have not actually translated into any clinical advantage. And we really need to await the results of the ongoing randomized proton versus photon trial and its relevant endpoints, namely survival, cardiac toxicity, and lymphocyte reduction. So now I'll move to the next topic, and specifically whether there is a possibility of causing a harm from the use of protons. And here I'll touch upon two main topics. The first is the uncertainty relating to the relative biological effectiveness of protons, and then the learning curve, which I have previously talked about briefly in the previous trial. We now know from big data analysis that there is evidence pointing towards a relationship between increased radiotherapy dose to certain cardiac substructures, particularly at the base of the heart, and you can see this here, with an increased risk of cardiac adverse events, which lead to heart attacks and premature death. And unlike breast cancer, in lung cancer, this seems to occur quite early on after treatment, with early separation of the curve as early as 6 months. We also know from the reported American trial, which I had shown earlier, that protons are able to reduce the mean heart dose compared to photon techniques. And we have indeed confirmed this with a small planning study that we did in Manchester with the help of UCL, but we we saw two crucial findings, I would say, which are important to note. First is that this preferential ability of protons to reduce mean hard dose seems to be reliant on the location of the tumor relative to where you want to spare. So definitely if you have overlap between the GTV and these sensitive cardiac substructures, which tends to occur whenever you have mediastinal nodes, you will not be able to spare these sensitive cardiac substructures. And the second thing that we noted is that there was no difference in the maximum dose, IMPT versus IMRT. And if you look at the previous big data analysis, these seem to show that the maximum dose rather than the mean dose is actually important and detrimental to outcome in these patients. What about the biological effects of protons, particularly at the distal end of the Bragg peak? So this is an example of the first case that we treated with protons in Manchester. And I think this is a case where it seems reasonable to treat with protons adenoid cystic carcinoma in a relatively young lady, which is expected to live long. And obviously with protons, you can reduce the dose to the breast as well as the lung and potentially to the heart. However, there is a problem with this Bragg peak, and indeed there could be increased toxicities associated with that distal end of the Bragg peak because of the uncertainty of the RBEs there. So we know that the RBE uncertainty could be anywhere between 0.7 and 1.6. And from this seminal paper, which was published quite a while ago, but still seems relevant, this has actually highlighted that the local hot region could lead to additional biological effects more than what we see on dosimetry, and that these need to be considered, particularly when that hot area overlaps with critical organs. And like I said, this is usually the case for stage 3 non-small cell lung cancer. The second issue is the learning curve. And I think there is no question in my mind, having already treated patients using protons in the lung, that a lot of caution needs to be exercised when treating these patients. And this is what we saw in Manchester ourselves. And we have also seen this in the previous trial, which showed that the incidence of radiation pneumonitis reduced over time. So you can see this with the yellow curves, showing that this is particularly true when implementing new techniques such as Proton. And I think this applies for both passive scattering and definitely for IMPT approaches. So I would say for the second question, I think it is possible to cause harm from the routine use of protons before a clinical trial is shown to be positive. And I would say the main reasons are the uncertainty of RBE and the potential learning curve. The third question is about practicality. Can we actually treat patients with lung cancer using protons? And at least if you use the British model, the NHS proton centers currently only have very limited capacity when it comes to treating patients. So that's less than 1.5% of the total radiotherapy capacity. And if you couple this with the high incidence of lung cancer, particularly stage 3, I don't think we have the capacity to treat all stage 3 non-small cell lung cancer patients with protons. And I would say we don't have a validated normal tissue complication probability model that we can use to select patients, because all of these have been developed using photon data, which might not necessarily be valid within the proton environment. And again, from a health economical standpoint, proton radiotherapy is probably at least 8 times more expensive than photons. And again, this is data from the UK model. So you would definitely need trial results to justify their use.
2 minutes left, sir.
Thank you. So in the end, this is my final slide. I would say that proton radiotherapy currently is not better than photon radiotherapy in locally advanced lung cancer because there is no level 1 evidence supporting it. We need to await the results of ongoing trials. And obviously there's many uncertainties relating to their use, namely the learning curve, and the RBE. And lastly, the impracticality and impossibility from a health economic standpoint to treat all locally advanced lung cancer patients currently with proton radiotherapy. Thank you.
Thank you. Thank you, Dr. Salem, for your excellent presentation. I'll move on to our next debater, Dr. Shrinivas Chilukuri. Dr. Chilukuri will be speaking against the motion. He is a senior radiation oncologist currently working in Apollo Proton Cancer Center, Chennai. So, as you all know, Apollo Chennai is the first center in India to get a proton beam radiotherapy, and he is credited with initiating South Asia and India's first clinical program for particle beam therapy for pediatric cancers, prostate cancer, thoracic cancers, and sarcomas. He is the co-founder and currently the chairman of Optimus Oncology, which has been working towards the modern cancer care to the rural pockets of India. Over to you, Dr. Chilukuri.
Thank you, Dr. Animesh. Thank you for this opportunity. You can hear me and see my slides, I hope.
Yes, we can. Yes, we can.
Great. That was an excellent presentation by my colleague, Dr. Salem. I congratulate. But of course, I would like to argue that there is a role for proton in locally advanced lung cancers. If I have to summarize why do we need to look for better options than what we have right now, is that there are many challenges for the thoracic radiation oncologist. Typically, if you go by the eligibility criteria as per the major randomized controlled trials for chemoradiation, which is the current standard, age less than 75, PS at least 2, weight loss less than 10% in last 3 months, FEV1 less than 40% of age predicted value, and adequate cardiac, renal, hematological functions. Even in a Swiss setting, what this study elegantly showed that nearly 1/3 of patients less than 60 were not eligible for concurrent chemoradiation. 50% of the patients were not eligible for concurrent chemoradiation between 60 and 70. Between 70 to 75, almost 60%, large majority did not qualify for concurrent chemoradiation, and almost as it defined less than 75. So every patient more than 75 years is not eligible for concurrent chemoradiation. This was in the Swiss setting. I can't even fathom to imagine what would be if we do the similar study in a setting like India. And in very few sites in human body, the acute dose-limiting toxicities actually determine overall survival. The esophagitis is known to, has been shown in RTOG 0617 to have an impact on overall survival. The volume of PTV, the heart V5, the location of the tumor, all these have been shown to be an important determinant of overall survival. We have subacute radiation pneumonitis. Of course, we have a group of patients who are more prone to that particular complication, but we've seen grade 3 radiation pneumonitis in about 5 to 10% across all studies, with 2% of them being even fatal. Cardiovascular toxicity, Dr. Salem actually mentioned very well that the median time to develop these toxicities is not beyond the lifespan of a lung cancer patient. In fact, it starts within 6 months, and you see complications actually within a year. And there is tremendous evidence to suggest that there is a large chunk of patients who do have cardiovascular complications, arrhythmias, ECG changes, and so on and so forth. And these also have been correlated with overall survival. We've already learned a little bit from the postoperative lung trial, which was published recently, that there is a large percentage of patients, again, who die of cardiopulmonary causes in this randomized trial, and grade 3-4 cardiopulmonary toxicities also were significantly large in patients who received, of course, this was 3D conformal radiation therapy in a great majority of the patients. We know what are the group of patients who where the cardiac doses could be significantly high. These could be patients who have subcarinal nodes or multinodal station involvement, or even contralateral hilar nodes, which actually increase the dose to the heart. And do we have a constraint to the heart? Do we know, is it the mean heart dose? Is it the pulmonary artery dose as RTOG 0617 in the modeling study showed the base of the heart? Is it, what is a structure? What is a cardiac substructure which can be taken as a surrogate for toxicity? We are still evolving. We are still learning. And what are the cutoffs? We are still evolving and we still don't know. And the best thing to spare as much as possible and as far as possible. Despite all these, we have underwhelming clinical outcomes. We know that a large majority of the patients have local failure, 40% regional failure, large distant failures. 2-year PFS was 30%. Of course, in the immunotherapy era, the 2-year PFS has improved from 30% to 50%. As the previous speakers have pointed out, there are limitations, and if you want to extrapolate specific trial into our setting, where it's sometimes unrealistic to expect that kind of patient population in day-to-day practice. Dr. Salem also mentioned about the lymphopenia which happens, and there is a correlation between lymphopenia and the outcomes in this systematic review and meta-analysis. Although Dr. Salem chose to show a very selective study of only 60 patients and treated that to 30 patients with protons and based entire argument against proton therapy on the basis of that retrospective study, I wouldn't agree with him. And there are a number of studies across sites, not just in lung cancer, esophageal cancers, which he mentioned. And there are many other sites which have clearly shown that lymphopenia seems to be definitely lesser in patients receiving proton beam therapy, essentially because, physical advantages of proton therapy. We all are aware of the physical advantage of proton therapy in terms of the Bragg peak. How is it different from the X-rays? The radiobiological uncertainty, of course, in a way, radiobiological uncertainty, if you use it you could use that as a strength. If you use multiple beams to avoid uncertainties, you could potentially use it. And there are ways to predict the LET, and LET-based optimizations are very soon going to be a reality and going to be in the clinic already. They are available as research modules on our commercially available treatment planning systems. And LET seems to be a reasonable surrogate for RBE, and it can be used. And if you use the RBE, higher RBE to our strength, it could be even a potential advantage. Evidence apart, this patient came to us almost 2 years back, 63-year-old gentleman with squamous cell carcinoma, T3, N3, lung cancer, diabetic, hypertensive, weight 120 kgs. He has obstructive sleep apnea, occasionally on oxygen, and the PET showed N3 node, because of which a patient was deemed unresectable. Apart from all the comorbids he had, the radiation oncologist in Mumbai ran an IMRT plan in breath hold, and he saw that the V20 was 36%, V5 was more than 60. Mean heart dose was 30 gray. He was not comfortable, so he sent the patient to induction chemotherapy. Wanted to reassess after a while, and nothing much changed, unfortunately. And when the patient came to us, we planned with the breath hold. Even though the patient was on oxygen, was able to hold breath comfortably for more than 20-25 seconds, and we could treat this patient under breath hold with proton beam therapy. And you can see that the mean heart dose came down from 30 gray to 7.2 gray, 20 gray mean dose to 12 gray, V20 36% to 22%, V5 more than 60% to 35.5%, thereby reducing significantly the probability of grade 3+ toxicity. This patient continues to be on follow-up, and this is March 2022. There are some post-radiation changes. But the PET is clear, and the patient is asymptomatic, relatively asymptomatic, and is doing very well and is on follow-up after nearly 2 years after proton beam therapy. This case is not an exception. There are now multiple dosimetric studies. Of course, these are small retrospective studies which have shown, and even single institution prospective studies which have been published, which have shown dosimetric superiority of proton beams. Showing varying, in fact, not just dosimetric superiority, but reducing the rates of severe pneumonitis, esophagitis in various small series. You can see the number of patients, about 62 protons, 134, 14, 64. So small retrospective studies, some phase 2 prospective studies as well, clearly showing that there seems to be reasonably good toxicity. So the harms which Dr. Salem emphasized are probably unfounded. Of course, there is a need for adaptive treatments. For this gentleman, we had to adapt treatment. This was the initial scan. This was the first week. Within 3 days, we saw a scan, and the CBCT picked up this slight increase in the size of the lesion within 3-4 days, and that caused significant dose perturbation. And we had to adaptively replan this patient. There is some underdose you can see here as well as near the nodal region. And we had to plan, in fact, twice we had to plan in this patient on basis of for adaptive replanning. We now know that IMPT seems to be significantly better than passive scattering. This is again another retrospective study, 139 patients. 62% received the older generation passive scattering proton therapy, 38% IMPT. With a median follow-up of close to 2.5 years. Grade 3 toxicities were higher in passive scattering. Grade 3 pulmonary toxicities were higher in passive scattering. Overall survival, of course, we will not go into overall survival, but clearly the toxicity of passive scattering seems to be much higher. The survival seems to be figuratively higher, but as I said, this is not statistically significant because this is a small patient study. National Cancer Database study again showed similar results. We know all the limitations of such analysis. Despite that, clearly proton beam therapy seems to have slightly better outcomes compared to conventional radiation therapy techniques in propensity matched to balance all the covariates in both in stage 2, stage 3 lung cancers. Of course, the cost effectiveness, I do agree with Dr. Salem. It is probably not yet cost effective, but there are some studies, at least in United States setting, such as this, which actually shown that proton beam therapy seems to have a promising cost effectiveness for a very few selected sites, including that in loco-regionally advanced non-small cell lung cancers. And we come back to the randomized trial, which Dr. Salem showed. Yes, it was a Bayesian adaptive. I have no complaints regarding the design of the study in general. But of course, if it is done well, Bayesian could be a good pragmatic approach to test a hypothesis, specifically in proton beam therapy, in proton field. But nevertheless, the fact is that patients who were randomized to protons did not receive protons. Patients who, in fact, a significant chunk, nearly 25% of patients were, patients who received either proton or photons, where the protons were the only acceptable plan on dosimetry. And of course, the biggest fallacy, issue with my issue with the trial is the passive scattering proton beam therapy, large safety margins used. I think these are older techniques which have been used, and I don't seem that they are relevant. Dr. Salem also mentioned that the primary endpoint was negative, although it showed that the hard doses were lower, which is absolutely right. And what he also showed that there was a clear learning curve with protons. And I think this everyone should understand that in the first half of the study, radiation pneumonitis being the primary endpoint, I think this is an important point.
Sir, 2 minutes left, sir.
Yeah, in the first half of study, 25% had pneumonitis, whereas in the second half, almost none had pneumonitis. And my problem with this study it is passive scattering. It is not the standard of care right now. There is a clear learning curve. RCT should be started after establishing a technique. It used pencil beam algorithm instead of Monte Carlo. We know the limitations of pencil beam class B algorithms, less frequent adaptive planning, large PTV volumes, and the design of the study itself are the key fallacies. and I think RTOG 1308, as well as another study from North America probably will enlighten us in more regarding proton beam therapy. And there are multiple phase 1 and phase 2 trials ongoing testing proton therapy. I think there is enough equipoise at least to do a randomized control trial. And of course, motion is an issue. We do have our own protocols. We use multiple fields, not just 2 or 3 fields, especially in lung. We do 4D robust evaluations. There are ways and means to overcome some of the RB uncertainties, which Dr. Salem mentioned. And we had initially presented initial 20 patients last year at ISRO in this study. And to conclude, proton therapy seems to have a potential in reducing toxicities, esophagitis, and cardiopulmonary toxicities. There are several theoretical advantages: immunological, higher radiobiological effects, with and without immunotherapy, the potential for safe treatment intensification with dose escalation, with hypofractionation and concurrent chemotherapy should be explored. And we have shown, actually I've skipped the slide, that there is a scope for hypofractionation with concurrent chemotherapy with protons. RCT evidence is required, there is no doubt about it, and hopefully it will emerge in the definitive setting. It seems to be very promising in post-operative setting. We have treated a few patients of post-operative lung cancers to very, very gratifying results. Recurrent setting is also something which has been published before. If you are reading a trial on protons for lung cancers, you must see that if it is not having IMPT, not having image guidance, Monte Carlo, motion managed, adaptive treatments, then I think it is not relevant as of today, because this is an older generation technology and that should not be used for any comparison. Of course, the cost and access remain the major challenge. Hopefully with smaller and smaller footprints of proton beams, these challenges can be overcome in the future. With this, I would like to conclude and thank the organizers for giving me this opportunity.
Thank you, Dr. Chilukuri, for your excellent talk. May I have some rebuttal comments from Dr. Salem?
Yes, so again, thank you very much for the very nice debate. I would say a couple of comments. First of all, I fully agree with you that LET optimization is something that we need to consider going forward. I would say the dosimetric superiority that you've shown is nice on the plans, but we never know for certain what it means. And, we have previously been surprised by the results of RTOG 0617, and it might be that the dosimetric advantages of protons that we see on the planning system might surprise us as to the biological effects that they actually cause. The case that you presented, I would say, might make maybe a good use of protons, but if this patient was presented to me, I'd probably just consent them for an increased risk of lung toxicity and treat them using standard of care photon approaches. And then finally, the final two messages and points are about the NC National Cancer Database that you've presented. So just bear this in mind, that yes, it had protons showing superior outcomes compared to photons, but it only included a very small number of proton patients, so around 300 compared to, I think, 20,000 patients treated with photons. And finally, practicality. You touched a very important point about adaptation of treatment, which I did not actually address. And I have to be very honest with you, proton treatments in lung are very complex. And, with the patient that we treated in Manchester, a lot of adaptation is necessary, usually like 1 or 2 adaptive scans. And I think coupled with the lack of availability of proton centers and the cost, adaptation just is a pain in the neck. And I think makes it very difficult to implement this routinely currently. But thank you very much again for all of your nice debate points.
So, Dr. Chilukuri, any comments?
Yes, I would agree that proton therapy I would not recommend as a blanket treatment for all locally advanced lung cancer patients. There's no doubt about it. But I was not very happy to hear Dr. Salem when he mentioned that he wouldn't refer that patient. I mean, there was a clear advantage of protons. So I would say that protons, depending on the location, depending on the PTV volumes, some should be considered for protons. Of course, for those who have access and are able to go to a proton center, of course. But there is, as far as science is concerned, there seems to be a huge potential definitely in certain percentage of patients. It could be 15%, it could be 20%, it could be 25% of locally advanced lung cancers. But I think there is a potential for benefit. And I think randomized trials, again, will get it wrong in the sense, because if you randomize all patients, all comers in upper lobe, lower lobe, central lesions and small PTVs, probably you will not get the right answer. But nevertheless, there will always be patients who would really benefit with protons, and agreed that radiobiological effects are uncertain in protons to an extent. But as I said, there are means to mitigate or minimize those effects, and dosimetry is the biggest surrogate we have in radiation oncology. And I agree that protons dosimetry doesn't reflect always what we see on the planning system. But to a large extent, it does. I mean, if you spare the majority of the lung, you would definitely, if you're not irradiating any part of the lung on the contralateral side, you would definitely not see any radiological effects on that lung. So I believe that there is a role for proton therapy in locally advanced lung cancers, and it is here to stay.
I've got a question to both of you. So for ILD patient, particularly with the fibrotic changes, we are always concerned about risk of pneumonitis. Sometimes it is considered as a contraindication for photon radiotherapy. So any experience of treating ILD patient, maybe non-fibrotic or fibrotic patient with treating proton therapy?
Yeah, Anish, I have treated 2 or 3 patients. Of course, the third patient is a very mild case of ILD, but 2 patients we have treated, not for locally advanced lung cancer, though. Patients have been of stage 1 lung cancers. In the setting of COVID, the lung was extremely unhealthy in the background of ILD and COVID. And a few suspicious nodes, which of course were biopsied, and both very gratifying results. We could treat them safely. I don't have a comparative study to tell you, but very small experience so far, last 3 years. So it can be done. Proton can be used in some patients, if not all patients.
Dr. Salem, any experience with that?
Yeah, so I think that's a very important point. I think that makes a very good case for the use of protons. In my eyes, even, I don't think you need a randomized study to show this, because I think there is no equipoise. These patients tend to have very poor outcomes with standard photon approaches. If you can reduce the dose to the lung, which you can definitely do with protons, I think in my eyes, yes, these patients need to be treated with protons, even stage 1 disease. So I would probably I think there is a stronger argument for stage 1 because they can live longer. The biggest problem I think that you're going to get is from the regulators and the people who reimburse protons there, because they might say, okay, well, these patients do very badly anyway, why would we do that? But I think that makes a very strong case for protons in my viewpoint.
Okay, thank you. I think we have to conclude our session here.